The title I was given is Brachytherapy or Prostatectomy. These are my disclosures. What I want to do is help you to appreciate the difference in potential toxicities between different modalities, and I think we're all well aware of those when they're used as single modalities. But more importantly, the focus of my talk is going to be aware of the cumulative toxicity of adding additional modalities, either for failure or as combination treatment, and understand the importance of patient education when sequential therapy is very likely. This kind of harkens back to Dr. McLaughlin's talk yesterday. So our real goal of treatment is the trifecta goal, which I think was first expressed by Dr. Scardino, which means absence of cancer, urinary continence and urinary quality of life, and sexual preservation. There are many options available, many factors going to affect outcome, both the oncologic presentation, the baseline function, the age of the patient, size of the prostate, and the pre-existing comorbidities. And often if you're trying to compare treatments, you're comparing very, very different populations. So I think we all need to remember the worst toxicity is recurrence. So you got to look at the oncologic efficacy of your treatment or your combination of treatment. And efficacy is often enhanced by multimodality treatment, whether it's planned up front the way we do it in a radiation approach or sequential given as needed. So the combinations enhance the efficacy, but they also enhance toxicity and decrease quality of life. So when you're talking about a patient, about a planned course of treatment, it needs to be evaluated by the whole package and not just one part of it. So if we're talking about brachytherapy and we know we're going to be combining it with external beam or with androgen deprivation, it's that whole package that we need to discuss and not just brachytherapy. And the same is also true, but less widely adopted for radical prostatectomy, when you know there's a really high risk that they're going to need external beam afterwards or even androgen deprivation. The other thing we need to remember that in North America, both active surveillance and especially reduced PSA screening are shifting the balance towards more aggressive and advanced disease so that we're using single modality less and less. And we have to keep that in mind and adjust it, our approach. Definition of high risk, we all know this, prior to surgery, T3, Gleason 8 to 10, PSA over 20. There's also pathologic features after radical prostatectomy of the high Gleason, positive margins, seminal vesicle involvement, extraprostatic extension. And when you have combinations of these factors, your risk of recurrence can be over 60% by 5 years. I think one of the best papers on this is one by Mullins, published in the Journal of Urology in 2012, where he looked at 4,500 radical prostatectomy patients. None of them had androgen deprivation or external beam. The surgeries were done between 1982 and 2011. And in the graphs here, on the left, you see Gleason 3 plus 4. Here it's Gleason 4 plus 3 or higher. And the top line is for organ-confined disease, then extraprostatic extension, no extraprostatic extension but margin positive, extraprostatic extension, margin negative, et cetera, et cetera. And I think the best summary is in the table at the bottom, especially if you look at the figures in the red box here. If you have a Gleason 4 plus 3 or higher, margin negative but extracapsular extension, you've only got a 40% chance of being free of recurrent disease, and these follow-ups were out to 15 years. And that falls to 27% if you're margin positive. And for 3 plus 4 and even 3 plus 3, you can see the figures there. So when you're counseling a patient or talking about treatment and they have these pathologic features, you need to take that into consideration. Well, that was surgeries that started back in 1982. Maybe it's different now. If we look at oncologic outcomes of radical prostatectomy in the active surveillance era, this was at a tertiary care Canadian University Centre, 2,600 patients. Their surgeries were done between 2002 and 2012. Young, median age 61. A third of them were favorable risk and half of them were intermediate risk. Only about 10% were high risk. And if we look at the surgical outcomes, for the patients that were high risk going into surgery, 55% were pathologic T3 and a third of them had positive margins. And if you look at what happened in terms of biochemical disease-free rates, for the intermediate risk group, only 60% are recurrence-free at 5 years, and for the high-risk group, 40%. And these results are actually identical to what Zumsteig is published in Prostate this year for favorable and unfavorable intermediate risk patients taken from the SEARCH database. So that was a Canadian center. Let's look at a premier American center. This was published by Bastian from the Johns Hopkins for clinical and pathologic outcomes after surgery. And what they did is they looked at the results for biopsy Gleason 8 to 10 prostate cancer, either operated on at Johns Hopkins by Patrick Walsh, or they also selected out patients that in the region from the SEARCH database from shared equal access regional centers. So they had 220 biopsy 8 to 10 patients at Johns Hopkins, 149 from the SEARCH database, and the 5 and 10-year biochemical recurrence-free rates were 40% and 27% by 10 years. If they had completely favorable pathology, it was all, prostate confined, margins negative, nodes negative, everything else, the 10-year recurrence-free rate was 50%. And these are biopsy 8 to 10. And, there's selected patients for surgery, certainly at Johns Hopkins. Probably a lot of them had, 1 or 2 cores. And the conclusion of the authors were, their first conclusion was dismay and disappointment. They didn't realize that this was as bad as it was. And they recommended that high-risk patients receive multimodality treatment. And this just shows their graphs, the overlapping graphs from Hopkins and the SEARCH database. So I tried to go through the literature to tease out surgical results. It's hard to do because you want the results that have been, they're high risk based on biopsy, and that's not often the way they're reported. It's often reported as high risk based on the final pathology, and you're trying to find out what additional treatments were used, how many had adjuvant radiation, how many had hormonal therapy. So it's kind of a hodgepodge, and it's hard to come up with really good data. But you can see that, this was the Hopkins one I just discussed. This Briganti's trial was 1,300 patients in many European centers, and overall for their high-risk patients, the disease-free was about 54% at 10 years. Robotic prostatectomies reported from Detroit and Cleveland and New York, 43% at 10 years. And so on. The numbers are all, they're in that same range of like 40 to 60%, and they vary according to the characteristics that you see there. If we try to do the same thing for brachytherapy-based regimens, now all these patients had external beam radiation, they all had brachytherapy, and the majority also had androgen deprivation. And you can see, the numbers kind of look better. They're sort of 75 to 90%, and I've tried to choose series that used a quasi-surgical definition of failure of a PSA less than 0.2 or less than 0.4, rather than nadir plus 2, which obviously includes a huge bias. So before all the urologists in the room get all huffy and say you can't do that, you're right, you can't do that. And there's a lot of reasons that we can't do that. We're comparing results across modalities can be very, very misleading. Obviously there's patient selection factors. It usually works the other way, though, because the younger patients and the healthier patients do tend to get surgery more often. The definition of failure, which I've also discussed, and I tried to minimize that by using radiation-based or brachytherapy-based series that used a PSA definition of 0.2 for failure. The treatment specifics are also going to be very different. The type of surgery, was it robotic, was it open, the skill of the surgeon, skill of the brachytherapist, the quality of the implant. All these other features go into it. But I think most fundamentally and importantly, the philosophy of treatment, because what I'm comparing is brachytherapy-based results for trimodality treatment. We have an upfront combination of hormones, radiotherapy, brachytherapy. All the cards are on the table. When you see the patient for the first time, this is what you're going to get, and you discuss the side effects of each of those components of treatment. Whereas the surgical approach, maybe not everywhere now, as we were hearing yesterday, but it tends to be a stepwise utilization of modalities, where they start off with surgery, and if it's all favorable, they watch, and even if it's unfavorable, they watch to see what happens to the PSA, and then bring in other modalities later on as required. So let's look at this trimodality approach in a little bit more detail for a couple of minutes. And what we're talking about is, for these high-risk patients, hormones for 9 to 12 months, external radiation, and brachytherapy. And of course, as you all know, this approach was pioneered by Neil Stone and Richard Stock in Mount Sinai in New York. And this is one of the earlier publications, but not the first. And they were doing this back in the early 1990s. But this report is on 360 patients that were high risk or had multiple intermediate risk features. 45 of them had positive seminal vesicles. Long follow-up. They had 3 months of hormones before their brachytherapy, but continued for a total of 9 months on average. Not many of the patients were biopsied, but those that were was weighted towards the ones with the rising PSA, as was discussed yesterday, and 97% had negative biopsies post-radiation. So 7-year freedom from PSA failures, 83%, and 94% of these men have a PSA that's less than 0.2. So this, of course, was the basis for the Canadian randomized trial, the Ascende trial, which Ascende stands for androgen suppression combined with elective nodal dose-escalated radiotherapy. So this provides level 1 evidence supporting that approach, and what was compared was 78 gray of external beam with 46 gray plus the brachytherapy boost. There were almost 400 men randomized, follow-ups 5 to 11 years, and they were all high risk or high tier intermediate risk. They all had a year of androgen deprivation. They all had pelvic radiotherapy, whole pelvis, 4,623. And then the ones in the external beam arm continued to a total prostate dose of 78 gray, whereas the ones in the brachytherapy arm had a iodine implant for 115 gray. 69% of these patients were NCCN high risk. And you can see that the treatment arm made a huge difference in outcome. Those men who did not receive brachytherapy had twice the risk of failure compared to those that did receive it. The hazard ratio is over 2. If you look at the biochemical progression-free survival using a nadir plus 2 definition, it's actually 21 percentage point difference at 9 years between the use of brachytherapy and absence of brachytherapy. 62% disease-free for 78 gray versus 83% if they had the brachytherapy boost. If you look at it by risk group, for the intermediate risk patients, it was 70% disease-free at 9 years with 78 gray versus 94% if they had brachytherapy. And for high risk, it's 58% versus 78% with the use of brachytherapy. If we use a surgical definition of failure, declaring a biochemical failure if the PSA is over 0.2, the difference is even much more impressive. At 9 years, only 30% of the men receiving 78 gray still have a PSA less than 0.2 versus 82% who had the brachytherapy boost. So this is a highly effective form of treatment for high-risk prostate cancer. I don't think anybody can argue with that. Overall, this trial wasn't powered for an overall survival difference. We're still following it for that. But out at 9 years, the p-value is 0.09. Whether this will ever become significant, we don't know because it's only 400 patients. So what about toxicity? First of all, these implants weren't done at one center by the best experts in the province or in Canada. They were done by 16 different radiation oncologists at 5 different centers, and the majority were done before we started incorporating MRI into the quality assurance. So the cumulative grade 3 GU toxicity at 5 years was 19%, versus 5% in the external beam arm. There wasn't a difference in the GI toxicity. It was 9% versus 4%. But the important thing here is that at 6 years, persistent grade 3 GU toxicity was only 6%. So maybe that's not too high a price to pay if you're going to be cured of your disease. Many of these toxicities were dealt with effectively, usually quite simply, a single dilatation. They resolved. The majority of them were strictures. And there's no difference in the GI toxicities. 95% of patients in both arms were either grade 0 or 1. So let's step back now and just look at the characteristic toxicities of single modality treatment. And we'll start with urinary function. This is a paper that was published this year by Johnson using Fox Chase data on 3,500 patients. 2,300 had IMRT, 300 LDR brachytherapy, 400 post-prostatectomy radiation, and also 400 had radical prostatectomy. So these are their baseline urinary function. The red ones are IPS scores 20 to 35, yellows 8 to 19, and the green ones are 0 to 7. If you look at urinary function post-treatment by modality for the 4 groups, you can see here that red is brachytherapy, and we all know about this. We know that and this is by IPS score. We know that there are irritative and obstructive symptoms that peak at, a month or 2 after the treatment and then take quite a long time to resolve. But by, 18 to 20 months, things are getting, pretty much back to normal. This, however, does not include incontinence, which is obviously going to be a feature after a radical prostatectomy. So if you look at urinary quality of life, not just the IPS score, you can see here in the black what happens after radical prostatectomy because of the incontinence, which by 12 months has, not resolved, but largely recovered. And again, quality of life for the brachy patients, they go through a long period here, but by a couple of years, most of them are pretty much back to normal. If you look at the effective treatment by the baseline IPS score, I find that my brachy patients who have perfect function beforehand are the ones that complain most because they're not used to getting up at night, they're not used to any problems. So again, you see that typical peak in brachytherapy and then gradually getting better. What's kind of interesting and a little bit surprising is the ones that had the worst function, the IPS scores at baseline of 22 to 25, all get better no matter what you do to them. So, I don't personally believe that a high IPS score should be a reason to exclude a person from a type of treatment. What can we say about quantifying urinary complications after radical prostatectomy? This was recently published this year from the National Health Service hospitals in England. Between the years of 2008 to 2012, 18,000 men had radical prostatectomies, and what they did was look at hospital admissions within 2 years after their surgery. They excluded anybody who had adjuvant or salvage external beam radiation. And 15% experienced at least one severe urinary complication, resulting in 3,600 hospital readmissions. And the most common thing were bladder outlet obstruction and artificial urinary sphincters. But this is kind of similar to the Ascende data where it was 20% grade 3 GU, and most of them got better. We don't know how these resolved and what the ultimate side effect rate was for these men. But this just shows the incidence in terms of hospital readmissions at about 15%. So let's look at single modality sexual function, again going to Johnson's article, and this is using the SHIM score. The green ones are SHIMs at baseline 22 to 25. Most of the post-prostatectomy patients do not have that kind of function, and then red is 1 to 11, and yellow is 12 to 21 at baseline. And so you can see sexual function here by modality. Both surgical prostatectomy and brachytherapy take a hit initially, and the surgical function tends to gradually recover over a 2-year period. Brachytherapy is pretty stable after the initial fall, and I'll show you some more data on that in a minute, and then declines basically at an age-related rate. If we look at erectile function after robotic prostatectomy, this was published just last year, 214 men with baseline function recorded, divided in the SHIM score categories. They defined potency as the ability to penetrate whether or not you were using PDE5s, and they evaluated these men every 3 months. So at 12 months and 24 months, potency rate was 43% and 49% overall. But obviously, this is going to be very function dependent, and the guys with the really good function at baseline, the SHIM scores of 22 to 25, 83% recovered. If you had only moderate function in the 12 to 21 range, it was about 50% recovery. So that's one of the problems with reporting sexual function for groups after treatment. But this shows the same thing graphically here. You can see the guys who started off the best recovered up to a higher level, whereas those that started off intermediate didn't recover nearly as much. So the problems are with reporting sexual function that you need an accurate denominator. Not everyone who's treated is potent at baseline. It's not a binary function, so fair, good, and very good are often lumped together as potent. It's extremely age-dependent, and the expectations are different. If you have a 50-year-old with perfect function, his expectations are very different from that of a 75-year-old. And you need also to account for the natural decline with age, because a 50-year-old, even if he's fully potent, when he gets to 60, may not be fully potent. So what's the natural decline, which has been defined, I think it's like 3% per year or something for men in their 60s. So you have to take that into account as well, because not everything that happens is the fault of treatment. So it's better to report 52% of patients potent 5 years after treatment instead of that. Look at the odds by age, report it according to baseline function. If there's full potency, then 74% potent at 5 years. If impaired potency, only 52%. As Snyder did, reporting by age, if they were under 60, 87% were potent at 5 years, 60 to 70, 68%, over 70, 42%. So these are the results. This was work done by Mira Keys, published in 2015, on the potency results for the BC patients treated with brachytherapy, all followed prospectively in our database with baseline and post-implant erectile function recorded. So there's 2,900 patients. Their median age is 66. And you can see here, this is baseline, and this is 6 weeks after their implant. And this was kind of surprising for most of us, because the big hit is right away. And we always say, well, this is radiation-induced. Well, it's probably not entirely radiation-induced. This suggests more needle trauma from the actual implant. And then there's recovery up to about 24 months, and then a slight decline, a slow decline. These are 6-month intervals, which is really very, very similar to the age-related decline that you see in men who haven't had treatment. So let's see what happens when you start combining modalities. If we look at that same database that I just showed you, this is erectile function preservation. Instead of seeing globally, it's by age group and by the use of hormonal therapy. So if you were under 60 when you had brachytherapy and you didn't have hormones, you have a 92% chance of preserving potency at 7 years follow-up. If you're 60 to 65, that's 85%, 65 to 70, 77%, et cetera, and it gets lower over as the age goes higher. If you're adding 6 months of androgen deprivation, the chances of maintaining your potency are 15 to 20% less. If you're in your early 60s and you have 6 months of androgen deprivation, that 85% falls to 66%. So you can't quote the patient, well, you've got an 85% chance of potency, here, take this androgen deprivation to shrink your prostate, because it changes things quite markedly. What happens if you add external beam to a single fraction of HDR? This is results from Gerard Morton in Toronto for intermediate risk patients. They had a 15 gray HDR brachytherapy plus hypofractionated external beam, and they were followed with the EPIC score, IPSS, SHIM scores, and the CTCAE version 3. Median follow-up of 5 years. So you can see here the urinary epic change from baseline to year 5. This was 91% to 85, bowel 98 to 96, sexual 63 to 35, and only 46% of the patients were potent at 5 years. Unfortunately, all we have in that publication is the global result. But you can see here that the percentage of men with SHIM scores between 22 and 30 declined mainly in that first year from baseline to year 1, and then remains very stable, or there's just a slight decline that could be related to aging. This shows the effects on the EPIC quality of life scores for urinary function, bowel function, hormonal function, and of course sexual function, which is the one that's taking the big hit. So how does the addition of external beam or androgen deprivation affect quality of life after surgery? It's hard to find this kind of data. This was published from the Italian group, Montorsi, Briganti. They're very well known in the European circles, in Journal of Urology in 2016. So 2,100 men had an open or robot-assisted radical prostatectomy. They defined continence as being pad-free. And 15% of these men received radiation, 10% as salvage, and 5% as adjuvant. The 3-year continence rates were 71% if there was no radiation, 59% if they had salvage, that's the one in the green, and 42% if they had adjuvant. Now, this is obviously going to depend, if Dr. McLaughlin were here, on how you're doing your radiation, how you're planning it, but this is what's currently happening. The same group looked at erectile function recovery and the use of external beam. So the same patients, they're relatively young, median age 62. The IIEF erectile function was defined as having a shim score greater than 22. The 3-year recovery of erectile function, if they did not have radiation, was 35%. With salvage radiation, it was 29%. And if they had adjuvant, it was 12%. If they had a nerve-sparing prostatectomy, which obviously is going to be key in preservation of erectile function, with no radiation, it was a 56% recovery, and adjuvant 35%. So, in this publication, in this population, combining treatments is obviously going to have effect on patients' quality of life. If we look at radical prostatectomy alone versus addition of external beam with or without androgen deprivation, Adam has published this in European Urology this year, 13,000 men, and they were evaluated annually by self-administered questionnaires. The external beam was 3D conformal, 66 grades, pretty normal. Median time to adjuvant was just over 3 months, and salvage 16 months. Continence was evaluated by the number of pads, and erections by the response to question 2 on the IIEF. Were the erections satisfactory for penetration? And you had to have an answer of 3 or higher. So they did propensity score matching. They had 688 pairs for radical prostatectomy versus radical prostatectomy plus external beam, 371 pairs for prostatectomy versus the addition of external beam and radiation, and 335 pairs for radical prostatectomy plus external beam versus radical prostatectomy, external beam, and hormones. And what they found was when you added external beam to radical prostatectomy, you had a 4% increase in incontinence at 3 years. And if you added androgen deprivation, it was a further 4% increase and a 3% increase in severe incontinence. If you added external beam, there was an 18% decrease in potency. And if you added ADT, a further 17% decrease. So you can see this on the graphs here. The solid lines are radical prostatectomy alone. The dotted line here adds radiation. The dotted line here adds radiation and ADT. And you can see that the green here is continence with only none or one pad. Here it's 1 or 2 pads or 3 or more pads. So you can see here the difference in adding radiation and hormones to continence status of the patients by the definition of 0 or 1 pads. And you can see here the difference also stands out in terms of potency. Here adding external beam, here adding external beam and ADT, and in terms of quality of life as well. So at 3 years, a probability of quality of life score over 83 was 68% for prostatectomy alone, 57% when you added external beam, and 48% if you also added hormones. So in summary, all treatments have side effects. I think still the worst toxicity is recurrence. Potency is better preserved in younger men, no matter what kind of treatment you're using. With radical prostatectomy, good function was reported 83% at 2 years. With LDR brachytherapy, if they're under 60, 92%, 60 to 65, 85% at 7 years. Incontinence is worse after surgery. We all know that. But it can be even worse if you're adding external beam. Severe urinary complications after prostatectomy in the National Health Service in England were 16%, which is kind of comparable to the grade 3 seen in the Ascende trial. In the Ascende trial, that was reduced to 6% with treatment, and I'm sure these fellows in the National Health Service also had successful resolution of many of their complications. When you're adding other treatments, things get worse. Potency rates for HDR and external beam were 46% at 5 years, but they didn't divide it up by prior function or age, so it's hard to tell. And as I mentioned in the Ascende trial, 6% persistent late grade 3 GU toxicity at 6 years. I don't think there's any sense arguing about brachytherapy alone or radical prostatectomy alone if the majority of the patients that we treat are going to get combined treatment. You need to assess it as a package, brachy plus external beam, trimodality, brachy, external beam, and hormones. Or if you're doing a radical prostatectomy on a high-risk patient, factor in the effects of the adjuvant radiation and possibly the addition of hormonal therapy. If there's a 50 to 60% chance that they're going to need additional treatment, it's a lot easier to discuss that with a patient after the treatment if they already knew about it beforehand. And what we really, really need, and which isn't available, is like 10-year trifecta scores for a surgery-based approach versus a brachytherapy-based approach. Thank you.